All right, hey guys. So we'll do another ultrasound/sim lecture series. So this is an intro to resuscitative TEE. And if you guys were expecting to walk into a critical care fellowship where you would learn TEE and felt like until now that promise was not delivered, well, the plan is to change that promise and absolutely deliver that absolutely crucial part of your critical care training to you over the next coming months. And the hope is that if you guys have the will, then everyone here will be able to graduate fellowship feeling somewhat proficient in TEE. And for the second years who are interviewing right now, I'm sure you guys have come across that in your interviews. That this is a becoming more and more popular part of your critical care practice. Um, but there's a lot of caveats to it, right? So coming from me, I am not a expert TEE um, resuscitationist. A lot of I'm just an enthusiast. I've gotten a lot of, as much as I can, experience doing it at Atlantic Care in the OR with the anesthesiologists, and then just kind of studying on my own. But nothing obviously replaces handheld time. And then, you know, I'm not an ER doc either, so I don't have all that experience being able to do it during cardiac arrest in the ER. But there's some pretty exciting evidence for. Um, I haven't had a chance to cannulate for ECMO using PE, like some of the attendings have, but I've had a chance to talk to them and I've tried to take their advice and then some of the tips and pearls and put them in. And then, obviously, if they join in, they can fill in as well. Um, so, we'll kind of go over some of like overall landscape. I'm not going to dive too much into the data. We'll save that for a follow-up lecture, but there's definitely a lot, and I can refer you guys to where that evidence is. We'll go over some of the main use cases from a critical care perspective, including with hemodynamics. We'll go over basic probe manipulation. We'll go over just the simple 4 views you need to know, as well as introduce a online module that you guys can do to practice on your own, kind of like Jared did with the Harvey simulator. Some practice pearls, and then at the end for whoever's on, for the fellows, we'll go over some practice TEs that are super easy to interpret, just so you guys can get some practice in. And please do stop me along the way. So I'm of the opinion, as you guys all know, that anyone who is critically ill absolutely deserves a probe on their chest. The heart is meant to be seen, not heard. The lungs are meant to be seen, not heard. And the number of times that I put a probe on the chest, as you guys are all familiar with, there's a lot of times where it changes your management or it gives you more clarity regarding your diagnosis. And what I've seen more and more, especially as our population landscape changes, is that sometimes these views are very hard to get. They're very difficult to do. And that's not even including the patients who are post cardiotomy, who have all this air in their chest from getting these devices and having an open chest. It's almost impossible to get an accurate view of the heart, because once again, air is ultrasound's worst enemy. And the only way to get a good picture is to go from behind through the esophagus. So if we go with the idea that anyone who is critically ill deserves focus, then anyone who is critically ill should be able to get a TEE if it is warranted, especially considering that, in my opinion, it is far easier to manipulate, far easier to visualize, and hopefully far easier to learn than transthoracic echo. We all walk into fellowship being asked to do these crazy things. And the biggest concern that people have with letting us get ATE probe is that it's too dangerous for these patients, is that we're not good enough to do it, or that it requires a lot of training. Well, let me say this. In my opinion, handing us a endotracheal tube and a blade is far more dangerous, and asking us to intubate within our first month of intubation is far more dangerous than asking us to use a TEE probe. These patients, as you guys all know, can die at any second. They're handing us a lethal weapon, especially those RSI meds, and we're expected to be experts in them. They're handing us needles to go put in central access that requires quite a bit of proficiency. The idea is that if you can't do a peripheral IV, you shouldn't be doing central lines, and that can cause a lot of complications, and that does cause a lot of complications. Especially if not done sterilely, or if there's like procedural complications. And then we're asked to manage ventilators, right? And ventilators are the type of the device that you can easily kill a patient within minutes, right? And so compared to all of these things that have a much higher complication rate than using a transesophageal probe, transesophageal probes overall should be a much safer procedure to learn. And the idea is that instead of being this fellow who can easily make a bunch of mistakes in the middle of the night, we want to be the shining doc who's able to accurately get great views of the heart and improve their diagnostic abilities, improve their treatment abilities, and overall help out our patients. So what are some of the indications? Where has TEE gotten very popular? there's a lot of interesting data out there, especially from the ER world, that about doing putting down a transesophageal probe during cardiac arrest. So after they've been intubated, as long as you've secured their airway, to help with CPR. And so what are the use cases? Well, one is to ensure adequate CPR. And we'll go over some practice images. Are we actually achieving good compressions, right? And you'll see a lot of naysayers about this that, no, we've got the end tidal, we're good enough, right? But there's more to than just ensuring adequate CPR, making sure that you're at the right place over the left chest, but the left side of the heart, but also making sure we're not missing out, reversible etiologies, right? Sometimes it's difficult to get transthoracic views, especially when we're trying to minimize lack of compression time, minimizing no compression time, aka no flow time. We want to maximize this low flow time when they're actually getting adequate compressions. And so that means allowing continuous compressions without having this maneuverability. Actually, no, don't start yet, and minimizing it to 10 seconds, because you have a picture of the heart continuously, right? So the moment you stop compressions, this idea of looking for a pulse check, you can see whether the heart's moving or not. You can figure out as soon as the patient, you hold compressions, is there that slow V-fib or not, right? And you can decide that, hey, maybe because of that mini V-fib, I want to shock the patient, that you wouldn't have realized by just palpating the patient or looking at the rhythm strips from outside the heart. And it's continuous. So hold compression for a few seconds, look at the heart, click record and resume it, and then you can just keep this probe in place, right? And yes, there's concern, maybe you'll hurt some teeth, maybe the probe is too expensive. But I think that as long as the evidence continues growing the way it is right now, and as long as we continue to build good CPR teams, it's going to become even more and more popular in our resuscitation for cardiac arrest. So post-CT
Hey, Uday.
surgery, not much to say there. Yes.
Just a question. So you're saying you're talking about using this literally during CPR, right? So,
Absolutely.
is this used in patients with both like mechanical or like physical chest compressions, mechanical chest compressions, or both? I'm just
Both.
worried like, so like, I mean, because that probe is much bigger than like most of the other things we have in that space. Is there any issues with damage when we have a okay.
If you are adequately, if you are, in the literature, you don't see those complications of damage to the probe. Just flying through literature, that's not one of the reported complications. The complications that you see is like, in the oral pharynx, trying to potentially emergently place it, potentially injuring the teeth. You know, with any TEE manipulation, if you don't do it safely, you can cause like, a bit of hemorrhage, hematomas, not hemorrhage, but, maybe a small bruising in the posterior oral pharynx and things like that, especially in these patients that, for whatever reason, they were arrested, are more likely to have poor protoplasm and things like that. So it does have to be done safely. But in terms of, a Lucas device doing mechanical compressions, you're not going to damage the TEE probe. You've got quite a bit of soft tissue in between. And really, you want to have adequate compressions. You want to be pushing down. Your probe is not going to be damaged. The actual probe itself, I mean, if you take out your index finger and then you look at it, that's the size of the camera probe of the TE. And we'll go over the image in a second.
Wow, that's fair. Cool.
Yep. So post-CT surgery, right? We talked about, you guys have been in the OR at Atlanticare. You guys see that there's an anesthesiologist with a TE probe that's just left inside the patient, for patients that require cannulation, for patients that require valve assessment, valve repair that's done through the vessels instead of open. You'll see that they have that probe and they're getting constant visualization. But what happens when you're taking care of these patients after they come to the CT ICU? Your patient goes into shock, right? We had a lecture a few weeks ago about resuscitation post-TAVR, especially the high-risk ones. You're trying to figure out why they're in shock. You're grabbing your ultrasound, and you look, and all you see is just blurriness, that grayscale image, because there's just so much air in the chest. You're not able to get accurate views because all that air is blurring, the space between your probe and your heart, and you're not able to adequately utilize the ultrasound to get good assessments. And so what if I needed those good assessments? What if I wanted to see if there was an issue with one of the valves, if one of the vessels, if there was a blood clot, right? More and more, you'll see that within CVICUs, there is an esophageal probe in the room, ready to go, kept inside the patient, either just for quick resuscitation or even just left inside until the patient stabilizes so they can do serial hemodynamics. And there's growing evidence for this. And so as intensivist staff, more and more CTICUs, something we should absolutely be pushing to be proficient on. And Europe is way ahead of us. I mean, you'll see programs from a training perspective they'll have a TEE probe in every room just sitting there ready to use. They'll put it inside the patient. If they still need it, they'll leave it in there. And if they don't need it, they'll take it out and then wash it, clean it and then hang it again. And so that if they need it again, it's ready to go. No surprise here, right? You've got to visualize in real time where your catheters are going, right? Where your guide wire is going before you continue the serial dilations, right? A lot of procedural complications can happen with this, and you'll see different centers do different things. Some will be able to use simple transthoracic echo. They'll look at the vessels from the outside, ensure there's guide wires in, and then they'll cannulate, and then they'll follow-up X-ray. But a lot of case reports of malpositioned catheters, procedural complications, especially with those 16 French all the way up to 27 French catheters, something that should be absolutely done under TE guidance, especially when it's available and can be done pretty quickly. Increases the proceduralist confidence that when they cannulate after the wires in, it's going to go in, right? Because under, like, for example, with ECPR, you're going to get these wires in, then you're going to administer heparin, and then you're going to start your serial dilations, and there's going to be a lot of bleeding. And then if you have a complication because your wire was not in the right place, it's very hard to come back from that, right? So you've already committed, you can't undo that commitment. And so that confidence, having that confidence, I think is just better for everyone. And so, this kind of goes along with resuscitation, right? I mean, just with anything that we do in the ICU, we've already gone through in separate lectures how crucial volume assessment and hemodynamic assessment can be in evaluating our patients with shock into deciding things like fluids, where the source of the shock is coming from, even if it's multifactorial, being able to better delineate what we want our next intervention to be or to guide our, practice in real time, giving us one more assessment. But in a lot of our patients, those views are difficult. In a lot of our patients, we're going to have to do it serially, right? More and more, I do agree that there's still some utility in the Swan Ganz catheter, the PA catheter balloon, but I think it's far less useful compared to good ultrasound images, especially if you can repeat them with similar accuracy and then get serial measurements that way, right? And so now imagine just having a TEE probe in and getting your serial assessments that way, deciding whether your interventions are, improving the patient's overall cardiac output, the patient's overall shock state. And even amongst providers, because, the overall maneuverability of a transesophageal probe is a lot more effective, a lot more controlled than the maneuverability of a transthoracic echo, because you're relying on, when we go into probe dynamics or probe knobology, you'll see that there's a lot more control over using a TE probe than a handheld ultrasound probe on the chest. And then, just it's not just about volume assessment. It kind of goes hand in hand with what we just talked about in resuscitation. But even like managing a patient on a ventilator, right? How many times have you put a patient on a ventilator who's dealing with hypoxia, made some vent changes, like, for example, put them on APRV or higher amounts of pressure, patient goes into a shock state, you're concerned about overdistension, you're not able to get good transthoracic views because you're hyperinflating their lungs. And then there's some case reports where, or even some expert opinion, where they'll put in the esophageal probe, they'll look at the RV and it's massively distended. They'll come down on their PEEP, figure out another way to make sure they adequately recruit the patient. And the moment they come down on that PEEP, that RV undistends because it's all acute, and their hemodynamics improve, right? So many, many different ways to use this, but for all our ways that we use, for many of the ways that we use transthoracic echo, you can use it for transesophageal echo, right? And so this is what your probe looks like, right? And obviously varies. So once again, you guys see the probe on the bottom right, that distal tip just as small as your finger. And you see this indentation, right? That is the side that you are going to enter it with. Once again, I've learned it not in the way that a cardiologist has learned it, just like I don't learn bronchoscopy in the way pulmonologists learn bronchoscopy. I go behind the patient. And primarily I say, because when I'm doing this, I've only done it with anesthesiologists in the OR, and they're behind the patient. But it was me, that's how most of us will learn it too. And you'll go behind the patient, allows me to feel more comfortable orienting myself. Everything is just reversed. Your beam direction is just reversed compared to when you're doing with transthoracic echo. And we'll go over how to understand that. So the key parts of the probe that you need to know is that you'll see 3 real knobs, A, B, and C. A is the one that you can change anteroflexion width and retroflexion width. So that probe at the distal end will either bend forward to where that beam is coming out or bend backwards. B, you won't really use that much, B as in boy. That allows lateral flexion. So what you're doing is you're going like if your probe is facing this way and your beam is going out this way, A will do this antero and B and going the other way will go like this. So this is where that beam is coming out. Anteroflexion, retroflexion. When you're doing anteroflexion, you're going to turn it towards C. So you're going to turn it towards where that knob is. So it'll go counterclockwise. And then if you're going clockwise, it'll go retroflexion. And then B is doing this. Does that make sense? So left and right, left and right. And then the other two maneuvers to know is that down and up. And the way you do that is the same way you do it with the bronchoscope, is that you're maneuvering the probe down and up. And what's important to keep in track of is that your TEE probe has white markers on it that helps you measure distance. And it's important to note those distances so that if you want to let the other providers know where you got your view, you can just mark the distance. Hey, I'm at 12 centimeters in, and that's where I'm getting this distance, or I'm at 15 centimeters in, and that's where I got this image. And then finally, you'll use more than you use B, which is just like a bronchoscope, you can rotate. And so the way I've been taught to hold the probe, I've been taught different ways to hold it, but the way I like it the most is that you take this probe and then you hold where that C is, pretend the C is over here. So you guys see this? Pretend that here's my knobs, here's the buttons, that C button, and I hold the probe down like this. And then this way I can maneuver the buttons like this, and then I can take the two knobs and control like this. And primarily, once again, you're just doing A and B. So if I turn A this way towards those buttons, as in, sorry, clockwise, then it'll go anteroflex. If I go counterclockwise, it'll go retroflex. And then from here, then you're doing downwards, upwards, downwards, upwards, and then rotating just near the mouth. Or you can even rotate from here. And then C is a unique probe manipulation. It's called probe rotation, kind of very similar to transthoracic echo. But instead of, when we talk about probe rotation on transthoracic echo, when I'm saying, okay, rotate it like this, here you're pressing a button to rotate it. And what you'll see is that if you look at that the top right image, that's how you're rotating it. So it's normally flat like this. The probe is, the angle's coming out like this, and this is 0 degrees. And then as you rotate it more, what's going to happen is it's going to go this way. And so you'll see that, okay, if I'm doing 90 degrees, it's going to look just like this, perpendicular to the probe. And then you can always go to a full 180 that way. And so
Udi, are we not rotating the handle like we do with the bronch for rotation at all?
you can, you absolutely do. So you can do it that way. I've been told to just do it this way, but it's just different by procedures, but you can absolutely rotate it this way. And you will do that, especially as you're trying to get your bicable view to look at both the superior vena cava and the inferior vena cava. The one that you'll rarely use is the lateral flexion. So any questions on those 4 movements? Awesome. Yeah, so once again, there's 5 ways to maneuver. You'll primarily use 4, very, very controlled. And when you're using the probe, you're going to have very able to, at every point, have specific instructions about exactly where you maneuvered your probes. That way, operator variancy, there's going to be good control. So if, I'm on service and, if I pretend I'm the intensivist on and I say, this is how I got the image, you can actually lock the probe and leave it in there for a couple hours, and the other person can come in and get the same image, or the next person can come in and then see where I got that image and then get the exact same image, so that way you can get the exact same measurements. Pretty cool, right? And so this is the resource that I really recommend that I found useful. I mean, there's quite a few out there, but I like this one because it's free. It's a bit old, and we'll kind of dive into it, but they had a lot of cool modules. Are you guys able to see the screen?
Yes.
Cool. So all this stuff is out of date now because it uses Flash. So unfortunately, you can't access simulation, the handbooks, the virtual stuff, the quizzes. But what you can access is learning the basic views. And so This is, obviously built for the anesthesiologist. You can access all 20 views. There's a lot of them, but that's not what you guys need to know. Are you guys able to see the moving pictures clearly?
Yep.
Awesome. So let's get ourselves oriented, right? So we've put the probe down. Um, you can see that the probe is right behind in the esophagus, facing the heart, right? And then this is at 0 degrees. It's facing directly straight forward. And I like to keep this on when I'm learning. So you can see that the green is over there, which is your left, the red is your right. And so now do you guys see how to manipulate yourselves to get this image? The way I think about it is if I'm standing behind the patient, I'm looking at it forward. And I'm basically seeing that if I am standing at the top of the screen and I'm looking straight in front of me, that's what I'm seeing. And that's how I like to think about it. And so when you look at this image, this is one of your 4 basic views that you guys should know. It's called the mid-esophageal forechamber. And we talk about our movements. It's about, you advance it at about 14 centimeters in, obviously varies by patient. And you'll keep the angle just about at 0. Maybe you adjust it just a little bit, the beam angle, but for most people, it should be in line. And by this view, this is equivalent to your apical forechamber on your transthoracic echo. You want to be able to see your left atrium, left ventricle, and right ventricle, as well as like clearly see both the bicuspid and the tricuspid valve. And then use it to assess things like chamber size, ventricular function, issues with the mitral or tricuspid valve, a possible atrial septal defect, and then a pretty good way to look at pericardial effusions as well. Maybe not the best. And then this is kind of like, once again, looking very clearly at what you're seeing. Should be pretty easy to identify. Any questions about this one? Pretty straightforward. Transthoracic echo, the easiest one to get because you literally get it as soon as you advance in. Very little maneuvering required. Awesome. So the next one that you should really, one of the second ones of the 4 views that you should know is the mid-esophageal long axis view. This is equivalent to your parasternal long. And so once again, you're looking at it from behind. And what you're doing is, as you advance, you're at that 14 centimeter mark, right? You don't have to advance any further. But what you do is you're going to, that beam rotation that we talked about, you're going to rotate it between 120 to 130, potentially 140 degrees. So you're taking that probe and you're saying, okay, I'm like this at 0 degrees, and I want to get this view. So I'm going to rotate the probe a little past 90 and like that. So I can get in plane with the long axis of the heart, right? Because the heart is on a rotated axis. And so when I look at what I'm exactly seeing, oops. Oh yeah, this way does the other way.
So this is an
So I've
inverted
wrote
like parasternal long, right?
absolutely. That's a good way to think about it, right? And the reason why you're doing that is because you really want that left atrium up here. You want the left ventricle over there, and then your left ventricular outflow tract over there. Does that kind of, you guys see it? There you go. I can redo it if it's hard to visualize. Once again, things that you're looking for here are really important. Your overall LV function, a better look at that mitral valve. You can't get an accurate left ventricular outflow tract VTI because you're not going to be in line with that probe, right? When we look at our apical 5 to look at our LVO TVTI, you can't really accurately get it from this view because you're not in line with this view, but I'll show you how to get it more accurately. And then you can obviously look at interventricular septum pathology. So once again, hope I'm not making anyone dizzy. Um, oops. So the probe is behind over there, and all you're doing is you're taking, remember that the green was initially over here. So if you're going to rotate it, you go past to 90 all the way here, and then a little more past into 130. Cool? Like 120 to 130. The next big one to use is your gastric short axis view. Where is that? And so this is equivalent to your parasternal short view, right? You can see your right ventricle, your overall left ventricular contractility, really, really helpful for looking at overall left ventricular function. And then, if you're looking at a little more of your mitral valve parameters, you can. For your patients with a STEMI, right, we always try and figure out which vessel is affecting which area, and then you can really break this down and break down which, area of the myocardium is affected by, for example, an acute STEMI, right? And so what we're doing here is that when you're looking at the back, you'll put the probe a lot further down, so you'll make it a lot more deep in going into the stomach. And then what you'll do is you'll move that A maneuver clockwise, and then you'll anti-flex, right? So you're here, and then you'll go anti-flex with the probe. And so you're going in the stomach and then looking up at the heart from above, and you'll get that parasternal short view, right? No rotation required. You just keep it at 0 degrees, and you'll look straight up. And then let's see. Do you guys see what that's showing? Good. And then finally, this view, very important for procedures. And so what you're going to do here is that you are going to, when you have the probe, you advance it to exactly where you were before, that 0 degrees. And then the difference is you're going to take your probe and you're going to turn it right. So you can look at both your SVC and your IVC entering your right atrium. And so all I've done is I've inserted about 10 to 12 centimeters. I am going to keep that beam rotation perpendicular. So instead of it being flat, now I'm rotating at 90 degrees. So I'm looking at it this way, because once again, I want to see that more vertical orientation of the heart. And then, this one can be kind of hard to get on the most of the simulators, and this is apparently universal. This is very hard to get sometimes. It's actually harder on a mannequin than it is on real patients. This is the view that you'll very commonly see in the OR, because of when they're trying to put people on bypass and things like that. And that's really the view that you'll get. And if you have them at 90, your SVC will be on top, your IVC will be on bottom. And
So
things
how
that you
did
can
you
assess
rotate the?
besides. Go
Sorry.
ahead.
How did you rotate the beam 90 degrees?
So this is this button right here. See this C button?
Uh-huh.
Yeah. So this, when you click this close to the probe, it rotates it, so it's more positive. And then when you push it back this way, it goes more. So this will go towards
Oh,
90
I see.
degrees. This will go towards 0.
Gotcha.
And so,
I misunderstood what the seat was
yeah.
for. Okay.
So, this is where I keep the wheels here. And then when you're holding the probe, you hold it like this, so that way your thumb can easily press these buttons. You see what I'm doing? So if those buttons, that C is right here, I can just press like this, and then I can also rotate the wheel. I have my middle finger and my thumb grabbing the A wheel, and then I can just move my thumb up to press those buttons if I keep it upside down like that. Cool.
You're saying it's the C trigger on there, right?
Correct.
So I guess I misunderstood. When you're saying that was rotating it previously, that's not rotating the probe like when you rotate the entire thing. It's just rotating at 90
The
degrees.
beam like this.
Gotcha. Okay, perfect. All right.
Yeah. To rotate like this, I'm really doing what I do with a bronchoscope and turning it
Yeah.
like this.
Okay. All right.
Or closer to the mouth, just turning it this way, where I'm inserting it. And I found this easier than rotating the entire probe. And then for all the other maneuvers, like going like this, you just use the A wheel. And then for advancing, where I'm holding, I just go up and down. Cool. And so, yeah, this is your final view. Very important, right? Like, for example, if you're inserting a pacemaker, you're going to see your wire come down this way. You'll put your introducer in, and then as you're advancing your pacemaker, you want to see it go this way and then into your ventricle, right? You don't want to see it go down to IVC. Versus when you're doing like, an ECMO cannula, you want to put your wire this way. You want to make sure that it goes down straight. And what you don't want to see is it curl up into your atrium, and you don't want to see it go into your ventricle, right? And we talk about those like dual lumen cannulas, like Avalon cannulas. Those are even harder, because you want to see your wire go all the way down this way into your IVC, and then one of the holes is here. The other one where the drainage cannula is here. The return cannula has to be directly facing your ventricle to shoot out blood this way, which is why what those downside of those dual lumen cannulas are. Any questions about those 4 views? If you know these 4 views and are comfortable with them, then the next time you guys are in the OR, you should feel very comfortable talking to your anesthesiologist, asking them to kind of, potentially maneuver the probe. As long as you kind of understand these 4 views, they'll be more open to it. And then you can also have a good idea of what's going on. And then you'll have, make better use of your time in the OR.
So these views
We're all
won't help me get a cardiac output, though, will they?
So for that one, what you're going to do is you're going to actually look at this view. You're going to go to that transgastric view, and then you're going to get that long axis view. So now you're more in line with your LVOT VTI, and you can put the probe this way, and then you can calculate your cardiac output. So for that one,
Hey Uday, this
based on
website, just because I have a CTICU next, this website, where
Yep.
like, is this something like free to the public, or is it an account?
Yep, absolutely. So it's right there, and that link is for you guys. And once again, I'll have this uploaded on our blog as well. This is what I've used to learn. There's a bunch of courses out there that you can pay for. There's textbooks out there that we have access to the lower library. Nothing replaces hands-on time with a simulator soon, next semester. But this is if you're going to make use of your time with a simulator, then I would learn this first.
And then when you're using that different view to get the cardiac output, I'm assuming because you're on the other side, you're going to be measuring above the line rather than below it for the VTI?
No, you're still like we do always, right? You're trying to measure right here at the outflow tract, not actually in the aorta.
Right. Well, no, I'm saying the inflection, like the wave goes, like we always measure it below that line on the ultrasound. I'm assuming in this one you measure above the line, or is it the same sort of waveform you're going to get for the VTI?
So I mean, it's the same, right? Because it's the flow is going away from the probe. Your cardiac, your flow out of the LVOT VTI is going to be going away from the probe.
Oh, I see it. Okay.
Your left atrium is here, left ventricle, outflow tract. Actually, let me confirm the transgastric. I forget. Yep. You see it? So you're measuring the flow going this way. Sorry, it was deep transgastric. So you want to go a lot lower. This is the view that you need to measure your LVOT VTI. And the way you're getting this view is that you're inserting the probe pretty far deep into the stomach. And then you see how low it goes. And then from really, really past that initial point that you were done, you'll anti-flex that probe even more as you advance, that you're really hugging the stomach around like this until you get to that LV apex, and then you'll shoot the beam this way. What you're really trying to do is that excessive anti-flexion, as much as you can turn the wheel this way, then really look up. And you can kind of see this over here. You see how far around the heart it goes, literally to the apex. Your stomach is coming down this way. You're going to go more and more and more, and then shoot the probe up this way back towards the vessels. And that's how you'll be in line with your left ventricular outflow tract. And it's called a deep transgastric long axis view. So now your beam is directly in line with your probe. And so now you can accurately measure your left ventricular outflow tract gradient. Make sense?
Yeah, I see it better from that angle.
Yep. Cool. So some of the clinical practice questions that we get is like, the joke is like, and I'm sure you guys have run this issue. You call the cardiologist and spoken to them, and asked for some extra time with them so you can do a transesophageal echo. And the responses I've gotten from a couple of them is that us as medical intensivists should not be doing transesophageal echo, that it's too dangerous. We don't have the training that they've done, an excessive amount of time training they've paid to take a bunch of courses even after they finish their cardiology fellowship, and really we should be doing it, and that's just not true. This is going to be standard of care, in my opinion, and just based on the way the evidence is going, and as we do more post-op cardiac care as intensivists, this is going to be extremely important on our end to be proficient at. In terms of it being hard to learn, I think transthoracic echo is far harder to learn because so much time is spent getting more accurate views. Trying to manipulate a probe on a patient's chest while they're awake, while they're moving around, while you've got the lungs in between. You've got to deal with the body habitus. I think that's far harder than learning how to place a probe in. And if you talk to GI fellows, they're putting they're doing endoscopy since day one with minimal complications. And so we as medical doctors are likely to be as proficient on it too. And these studies have been done, right? So there have been programs in the US, very commonly in the East Coast, where they will teach all their fellows transesophageal echo from day one. They'll make sure they're proficient in transthoracic echo so they understand anatomy. They'll spend some time with the simulators. They'll all be proficient with the simulators, and then they'll start doing real life exams. And for example, one study, it was decided that it took about 30 good reports on a simulator before they let them do on real life patients, and within 10 good reports, they were deemed proficient on real life patients. So pretty straightforward to do. This one's to me hilarious, right? Like, there's no data that TE saves lives. Well, there's no data that mechanical ventilators save lives. There's no data that CT scans save lives, but we use them anyways, right? And I think that we're just not asking the right question, right? Does it improve a intensivist practice, right? Does it help them make better decisions? And that data is out there too, right? So there have been both fellowship programs and like non-fellowship programs that have studied this, and they've said, okay, looking at a patient, did I have an answer to why a patient's in shock? And then they did a transthoracic echo, and 80 to 85% of them got a pretty strong answer or a pretty confident answer as to the cause of the shock. And then for the remaining 14%, they did transesophageal echo, and then only like 1 to 2% was left where they didn't feel like they had an answer. They filled in that gap, which is pretty big. So it definitely affects, being able to at least figure it out, right? Whether it and improves the final outcome or not, I agree, it's questionable, but I do think it makes a difference when it gives you more clarity or more confidence in what you're doing practice management wise. I do think it gives you more clarity or confidence when you possibly are able to elucidate a diagnosis before, regardless of which way the patient turns. And then in regards to that last one, right, credentialing is different than certification. So certification is more a society determined versus credentialing is more hospital determined, and it varies by institution, and there's not much control we can do for that. So certification, if you are interested in getting certified, you would first get certified in transthoracic echo based on the that exam that a few of us are taking in January, and then you can go ahead and do the transesophageal as well.
Yeah, I agree. I don't think it's not really the right question to be asking. That's like it's a diagnostic test, right? So it's like asking, like, does a BMP save lives? Like, no, it's just more information.
Absolutely.
think for
And
me,
so, go ahead.
today, but me, the more as intensivists we can do on our own to take care of our patients, I'm all for it. But the TEE outside of CTICU, I don't know. Like, I'm not seeing this used in MICU. Like, what scenarios outside CT? Because our cardiac patients are going to need this would greatly benefit them. But outside of that, like, this is not going to be done in MICU or anything like that. I assume. But I guess
I disagree.
in terms of like,
I disagree, right?
huh?
So, have you guys ever put on a transthoracic echo on a patient that's in, hypertensive emergency and then ends up being in profound shock? The moment you just give them any type of afterload reducer, right? I've seen it, and sometimes it's impossible to get those views. But half the time, I'm not able to diagnose it because you look at the overall clinical example of this patient. 500 pounds, very difficult to get good views on. They end up being emergently intubated, and now they're crashing. And then what you end up seeing, if you're lucky enough to get the view, is you'll see like profound MR, and then you get that blood pressure under control, and then finally they stabilize, right? These patients warrant a TEE because you can diagnose it earlier. Imagine this patient's in profound shock. You're not getting a good view. you quickly put that transesophageal probe down. You immediately identify that there's a huge vegetation that you didn't see in your transthoracic view. You can just take a picture of that, record it, send it to your interventionalist. You can leave the probe in there if you need to, so they can see it themselves. You don't have to wait for a CT scan. You don't have to wait the next day to get a formal echo. And you can send that patient to the OR the same day, because there's a indication for intervention for this patient, for example, a profound shock state or whatever. So a lot of useful cases for this. And then obviously procedurally, as medical intensivists, like if you join a hospital that is trying to pursue ECPR and you try to do these emergent cannulations, I am not proficient in that. I hope to be one day, but I would feel more comfortable cannulating knowing where my wire is.
You know what? Now you mention it, I'm pretty sure there's been debated patients who I get terrible views doing the TTE. Probably.
Yeah, I mean, look at all your obese patients, right? It's very, very difficult to get good views, right? Because the heart is just so far away from the chest, and I'm not able to. I'll always take a look, but a lot of the times I have to say that I can spend another 10, 15 minutes on this patient, but I'm not going to, even if I get some okay pictures, I would not feel confident making assessments on this patient that would affect my management based on those poor pictures, because it could be just so many things that I'm not seeing that could affect my measurements.
Sure.
Because if you have, we'll go through some pictures and you look at the quality of these transesophageal pictures, even under emergent scenarios, like you're getting pretty good pictures where you can make much more accurate assessments. And if you're like one of those maestros and get really good at assessing valvular pathology, then imagine how much of a difference it can make when you're trying to manage these patients. So, absolutely not. You should not be stopping compressions. Like things that you may run into is like, breaking off some teeth, causing a bit of a hematoma. But, once again, compressions are still the one thing that saves lives. And if compressions are the one thing that save lives, then don't you want to ensure that your compressions are adequate? Don't you want to make sure that when the person is doing chest compressions, that are adequately compressing on that LV and successfully getting the blood out of the left ventricular outflow tract? Because you can catch that, right? And yes, you can absolutely leave the TEE probe in the esophagus during defibrillation, just only touching the probe. And so during probe insertion, well, how long can it be left in? Well, it can safely be left in for a couple hours. You can take it out, you can get it properly cleaned, and then you can leave it hanging in the room. And then if you decide that the next provider is going to use it again, or if you come back the next day and want to make serial assessments, then you can do that again. And then, in what positions is it safe to advance and withdraw the probe? Generally it's deemed safer that you put the probe back in that neutral position, so there's not anti-flex or retroflex. Obviously, if you made any maneuverability with lateral flexion, then you fix that before you continue to advance or withdraw the probe. And so, in regards to the question of anticoagulation, I've heard different things from different providers, but I don't think it makes a difference, right? It's a low bleeding procedure. And so, I tried to find some blogs on this, and then obviously asked cardiologists as well as anesthesiologists about this. And almost all of them have said that they don't hold anticoagulation, right? Well, think about it this way. You have a patient who's going in for DC cardioversion. They're going to get a TEE right before the procedure. They've had heparin held, heparin continued pretty much until that standpoint, because they're concerned about risk of embolus. They still insert the TEE probe. And, some of the videos that I watched, lectures by intensivists that practice this and teach this routinely with their group, they will even consider doing it on a patient in triple therapy because the bleeding risk is just so low. So now, what about the patient that, obviously if the patient has a stricture, you don't want to put the probe in, right? If they've got that diverticulum or that Zenker's diverticulum, you don't want to put that probe in there, right? Because it can cause a lot of mechanical complications that are pretty severe. What about the one with varices, right? That patient comes in with liver failure. This is where I think it's good to get the gastroenterologist there with you to talk to them about it and then kind of make a risk-benefit discussion. And usually what will happen is the GI doc will ask you, how necessary is this procedure? How much is it going to actually affect your management? And then if it's absolutely necessary, maybe what they'll potentially consider is they'll consider doing a EGD before you put that TE probe in so they can get a proper look. And then if not, then you can go, and if they take a look and it looks good, or what they can potentially do is have you do the procedure with them in the room, and so if there's any complications, they can intervene and take a look as well.
Is this just until the next lecture where you tell us we can go ahead and clip some varices?
No.
We're already in the esophagus.
It would probably happen faster if we could do it.
And we don't have to worry about making sure their hemoglobin is over 8. Oh wait, no. Now they're too stable. So follow up outpatient.
All right, so you guys ready to do some practice questions? What I recommend doing is that if you guys are interested in learning, reach out to a few people. Obviously spend some time with that online simulator so you guys are comfortable with the views. You do your part, and then you can really bug these guys about them doing their part and potentially getting some hands-on time with the simulators. They are available, and then they can, they're obviously experts at this. They've been doing it for a while, and so if I recommend anyone to learn and get some hands-on time, it's these guys. And then shout out to these guys because introduced me to the anesthesiologists, and then got some time to spend with them, show them that I was interested in doing this. And so what I would do is when I'm at AC, I'll go in super early. And try to go in super early and then go immediately to the OR if I know there's cases going. Just talk it over with the anesthesiologist. So I'm there from that initial get-go when they're putting the TEE probe in, get some time to manipulate, especially while the surgeons aren't doing much, while they're getting prepped and ready. This way I can get my views, I can get some hands-on practice time. And then even throughout the entire procedure, right? If you're just watching the surgeons operate, great, but this way you can kind of keep yourself excited by getting some time to practice the TE probe. And if they're not requiring it actively, it's just left in there, and then you can kind of get some practice. And then obviously push this, guy on the right. So yeah, it's tea time. We'll do some practice questions. You guys can just take turns. I can't see who's on the screen. How much time do we have? We start a bit late, so maybe we'll just do 5 minutes of this. Cool. So when you guys are looking at these pictures, obviously, first identify what view you're in. Think about what you had to get there, and then identify the structures, and then if you can, identify the pathology. Does anyone want to go first? Alok, you want to give this one a try? So what view am I in?
I can't remember the name of the views, but it looks like that first one you showed us.
Right? Yeah,
Okay.
absolutely right. So one way to think about it is, if this were, what am I seeing?
4-chamber view. So this looks
So
like
it's your
kind of an
mid-esophageal chamber.
off-axis apical 4.
Absolutely right. And so you're seeing. So where's your what is this structure right here? Can you see my mouse?
I'm assuming left ventricle.
No, right. So you're going from the back and you're going forward, right? So this is your left atrium because this is your esophagus is right here.
Ah, I see what you're saying. Yeah.
Right. So you really advance the probe down here. You're looking forward. So the way I think about it is that I'm sitting here behind the patient and I'm looking forward like this. And what I'm seeing on my screen is literally the opposite. So if I'm looking down at the screen from where I am, that's what I'm seeing. So my head is right here looking down this way. And that's why I like standing behind the patient, so it's equal to what I'm seeing. Kind of make sense?
Yeah, I see what you're saying.
So left
right atrium is very
left
dilated.
ventricle. Yeah, absolutely right. Your right atrium is very dilated. So what would you say about the overall function of the heart? Of the ventricles?
The ventricle function overall still looks depressed.
Yeah, absolutely right. So you've got depressed LV function and depressed RV function, and a notably dilated RA. And another clue to help you is, like, you see this probe right here. You'll see this on TEs, and so you're just going down. You're not rotating the beam at all. It's really flat, right? Awesome. Gibson, you want to give this one a try?
Sure, same view.
Yeah, mid-esophageal 4-chamber.
Yeah, but let's see what's going on. This LV looks pretty hyperdynamic, I feel like.
Yeah, absolutely. What do you think
guessing,
about the
yeah.
RV?
I see a catheter or whatever. I think that's the lead.
That's just your
Let's
papillary
see.
muscle.
What's that white linear hypoechoic thing?
It might be a
going on
lead,
there?
actually. I think it might just be papillary muscle, but it might be. I'm not sure.
Otherwise,
But
I
what do you
have a
think about the overall
hyperdynamic
RV?
heart. Say that one more
So
time?
you've got a hyperdynamic LV. What do you think about the RV?
Ooh, the septum's fine, but to me it's fine. I feel like it's not too
I think the RV function is
remarkable.
overall pretty depressed, right? You look at that tricuspid annulus, it's really not moving that much. And you look at the
Okay.
overall squeeze of the RV, it's pretty low. So I would say you've got a hyperdynamic LV with a depressed RV function.
So we got
And this
failure
actually,
going on
you
here.
might actually this might be a ICD or a pacemaker. And what does commonly happen, I think more and more, is that patients with these long-standing indwelling RV catheters will start to develop worsening of their RV function. All right. Anyone else? Do anyone give this one a try?
Do a group
I can't
effort
see.
here. Me and Sanjay, me and Jay are both here.
We'll tag team it.
Awesome.
So I don't know the name of the view.
Well,
But
you know, what is the equivalent on your transthoracic echo?
What's your apical? Say that again.
So the equivalent on your transthoracic echo is likely a 4-chamber, right? And so
Yeah.
the most common way to get that 4-chamber is mid-esophagus 4-chamber.
Okay.
Yeah, and then
So
another
the-
clue is that you haven't rotated the beam at all. You're just looking straight at it. And the one of the few times where you're not going to rotate the beam at all is that mid-esophageal 4-chamber view.
So you're still seeing it from the same like orientation, like left.
Absolutely.
Your left side is on the
one is
right.
exact same. Yep.
Yeah. So your
yeah.
mitral valve has a friend on top of it, I think.
Yeah, it looks like a
vegetation.
Goomba on top of it.
Yeah, so that's what's happening is that you had complete cord rupture, right? This area, that muscle is supposed to tie it down to here, and it's not, and it's literally torn apart. And then so you've got a flail chordae. And this patient, if you put color Doppler on it, likely has profound MR. And if the dilated LA isn't a clue to that, then I don't know what is. You can see barely any volume in the LV because all of it's just, instead of going out the left ventricular outflow tract, is just being thrown right back into the left atrium. All right. Alok, or I don't know if anyone else, I can't see the screen, but we can just we can keep going down in the same circle.
Yeah, this is
what
this is
is-
that inverted parasternal long.
Yeah,
With
so what I would say,
the right ventricle being away from the probe.
yeah, so
furthest
what I
away.
would say is that you still want to click, right? We talked about like when you're doing sign out for this, or when you're letting another provider know what view you're in, you want to clarify both anterior and how advanced or withdrawn that probe is. So I would say this is mid-esophageal, usually around 12 centimeters, and then parasternal long. And so the way you get the parasternal long, right? You talked about that beam rotation, and so what you're doing with that beam rotation is you're turning it past 90 degrees and then a little more into 130 degrees, so you get that view. And so what you're seeing here, what structures do you think is what? Like what is over here?
Left atrium, right? Oh, where your cursor is.
Yep, absolutely. So this is your mitral valve, this is your left ventricle, this is your left ventricular outflow tract. Cool. Pretty straightforward, overall normal function, no real issues. I think I already included this one.
This is that apical when you're below the heart, right? When you've wrapped around.
No, this is in your mid-esophageal 4-chamber.
Okay.
All right, what's going on here? So this is once again similar to the one that you just saw. It's your mid-esophageal parasternal long, or sorry, your mid-esophageal long axis view. And what's going on here? So you once again rotate that thing to 130 degrees. What's going on over here?
Yeah.
What do you notice
so
about the left
what we're-
atrium?
Left atrium just
Is-
is so
Mm.
smoky.
Smoky. Yeah, it looks like so so definitely dilated.
Probably a lot of regurg.
Yeah, I agree.
So not a lot of flow in the LV, right? So what you see is a lot of spontaneous echo contrast in the left atrium. And the reason this is likely happening is pretty profound mitral stenosis. And this is where you kind of rely on your gradient measurements, things like that for valvular pathology.
Yeah. It's not really opening. Gotcha.
Yeah. What do you think about this one?
Did you
So
just
this
say
is not one of
Jupiter
the
is the
views we're
biggest
over-
planet?
Don't worry about that. What do you think about this view? So this view we didn't really go over, but it's just a little bit, you're basically optimizing
ventricular
it. So you
outflow
can
tract?
Yeah, absolutely. You're basically just rotating it a little less. You don't have to do the 130, right? It's about knowing how to orient your probe so you get the perfect view, but still mid-esophageal. And I would really call it a mid-esophageal aortic long axis view. And what are you, you're seeing that your left ventricle is somewhere here, and you're trying to focus on the left ventricle outflow tract. You see it here, then you go out, and then it just kind of falls. There's a bit of a descent. There's this subnormal thing. What do you guys think is going on?
Look, doesn't look like there's much opening, so I'm gonna guess aortic stenosis.
So if you had aortic stenosis, would your outflow tract be this big? Would you get this like big descent? And would it be wide open like this?
Dissection.
Because if you had aortic stenosis,
Is
your
that a
left
dissection
ventricle,
flap? Is that what that is?
yep, that's a dissection
yeah.
flap. Right, and TE is like one of the best ways to pick this up. And so you can obviously do transthoracic echo. If you're lucky, what you would do is that you would put the probe up here and look down with transthoracic echo, that supraclavicular view. We've picked it up. We picked up an aortic dissection like this before, but I want to get a CT scan to see this. Versus if I have a patient in shock and I put that probe down because they're that sick, they might not be stable for a CT. And you put this probe down, you've identified your problem, and you can get them to the OR a lot sooner than if you relied on the CT, which is I still look as the donut of death.
So how adequately are you able to visualize that early part of the aortic arch?
Very clearly, right? So I mean, this is like, oh, you mean with transthoracic?
Yeah, no, with TEE, like as compared to transthoracic.
This is a view. You're going to go down, and then you're just going to turn your probe a little bit so that you can see the aorta. You'll also see a bit of that. You're trying to focus more on the aorta than you are on the left ventricle, and then you're getting this like long axis view of your aorta before it descends, before it hits the arch, and then you can see right past the outflow tract this pretty large flap coming all the way down. And you can also then visualize this from you can go down to the gastric, look up, and then get a short axis view. And then what you can do is you can, instead of spanning it all the way down, you can go back up here, shoot it up this way. And then what you'll see is that flap kind of obscuring. And then you can see, is the flow coming out of this valve? And is there a second false lumen or not? Just to move things along. This is one of those like altered views. What you're looking at here is this is your mid-esophageal ascending short aorta axis, aortic short axis. And what you're doing here is that you're basically getting that main pulmonary artery view. So orient yourselves, you're going this way, and then this is going towards the right, right? So it's going backwards into the woods, which is where it branches, goes into left pulmonary artery, right pulmonary artery. What's that nice little bugger over there?
A long lost friend.
Yeah, I'm looking at this and I'm saying, someone hand me TPA, please. And then if the patient is, I'm concerned about this patient, let's get ready to cannulate this guy. But you can imagine how, I don't think this is the guy that you want sitting in a CT scan. I think this is the guy that, if you had a transesophageal pro as a MICU intensivist, you'll get this picture, you'll take a video, you'll call your interventionalist, you'll call and let them know that, hey, we're going to be strongly considering, you should get in here now for a clot extraction. All right, what's going on here? So this is, I'll give you guys a clue on this one, unless someone's able to tell me what view this is.
It looks like oh, actually, I was gonna guess left ventricle, but now I'm second guessing it. Is that the aortic outflow tract right there?
No. So I'll give you a clue. This probe has
left
been
atrium?
turned towards the right. So I'm going down this way, and I'm going like this towards my right side. I'm
Oh, so the right ventricle,
ventricle.
and that's into the pulmonary artery.
So I'm keeping it around 90 degrees. I've moved it, I've adjusted this slightly, which you'll do in a lot of patients, past 90 degrees. And what you're looking at is the bicable view. So this is your superior vena cava. This is your inferior vena cava. This is your right atrium. And so if this is your right atrium, what's that? that is your left atrium, and there's obviously a lot of flow going between the left atrium and the right atrium. This is a atrial defect. Now imagine if you didn't know this patient had this and you're trying to advance a guide wire into it for ECMO, and the guide wire goes here and then into the left atrium. Imagine how dangerous that would be. What's going on over here? Anyone have any idea? Along with Gibson?
That looks like a standard apical 4.
Yeah, but what's all this?
Chest compressions.
Yeah, right. So someone's actively undergoing CPR. This is the type of views that you will get. And what you want to try and figure out is, are you getting blood flow out of that left ventricular outflow tract? I'd actually be concerned about this patient because I'm not seeing that left ventricle squeeze line,
Yeah, it looks the exact same as
right?
always.
Yeah, I'm concerned that maybe I'm not over the heart, right? I want to tell the person doing CPR to adjust their chest compression so that they go maybe more over the left chest, and I want to start seeing that LV squeeze, right? And what we identify also is that in these patients where we start doing, TE in CPR, is that something that you get concerned about is that, are you compressing the left ventricular outflow tract, right? Maybe you're right over this area. This one, obviously, you can see opens up, right? As you compress, you can see it send blood flow out. But what if I was compressing and I was doing it in a way where I was right going past the septum right here in this area, in this axis, and I was compressing there, and I'm occluding my left ventricular outflow tract with compressions, and my compressions are actually making it worse. Not worse, but they're ineffective compressions.
Almost like a
So
SAM physiology.
this is what ineffective compressions looks like. What's happening over here, right? So you've got your left atrium over here, got your left ventricle. Once again, this is your mid-esophageal long axis view. You've got your left atrium here, your left ventricle here. Look at that left ventricular outflow tract just completely compressed. You guys see it? I need to readjust the way I'm doing compressions because this is not helping the patient. So this is being done by a Lucas device. That's why you can see it's so rhythmic. That is that mechanical device. It's so rhythmic, and so they saw this. They were concerned about ineffective compressions, so they switched over to manual compressions, and then they got this. And they're like, all right, we're good to go. But they switched over to manual compressions. This patient comes in profound shock. They see this massive regurgitation. They take a video. They call the interventionalist. They put an ECMO. They put this guy on VA ECMO, and then immediately had the valve repaired with a mitral clip the same day. What's this? What view is this? So look at it. It's about 90 degrees. So it's that bicaval view, right? Superior vena cava, inferior vena cava. What's this going? What's this? All this right here.
It's one of your ECMO lines, I'm
Hello?
assuming, or the wire.
Yeah, it's an ECMO cannula, right? You can see that the ends of the catheter over here. It's going from the SVC into almost the IVC. Imagine trying to do this procedure and then you enter the wire, goes like this, and then curls up in your RA, and then you decide to advance this catheter. That could be pretty dangerous. I'll send you guys a lecture in next week's email that I thought was pretty cool. And they have some really crazy cases with some crazy ECMO cannulations. Once again, not effective manual chest compressions. They readjusted, now amazing manual chest compressions. They went from the Lucas device, mechanical chest compressions. Look at this, it's not moving at all. You've got the Lucas device on, but it's not even touching the heart. Now you've got better compressions. Another clot, someone help this guy. This one, left ventricle, profound aortic stenosis. There's just no flow in the left atrium. They put the cardiac output, you see nothing coming out of that LV. There's just clots building up in the left ventricle, and the aortic valve is just completely occluded, or the mitral valve is just completely stenosed. All I have for you guys. Any questions? This is once again just a basic intro. If you guys can walk away knowing your basic 4 views, get some excitement, push your attendings to get you some practice on this. So when you're at Atlantic Care, make use of your time there. Spend the time in the OR with the anesthesiologist. If you let them know that you're studying hard at home, understanding these views, they're happy to help you out and get you some hands-on time. And that's all I have. Any questions? I'll send the link in next week's email to the simulator online as well.